because every time I lie, something happens like that. Anyhow, how do we get the encounter history? How do we get all the lab test results, the diagnostics, the immunizations, etc., applied in a consistent way when you're pulling it from all of these different places? So one of the things that we did is we put some of the bedrock down, which is the architecture and the standards. The architecture is very similar to the banking architecture. It's an SOA, it's a system-oriented architecture, which is basically repository-based. We didn't have enough money when we got started to go in and start to fund doctors' offices and to fund hospitals and long-term care facilities, etc. So what we did is said, okay, what we will do is that we build jurisdictional repositories of data. So drug repositories, lab repositories, diagnostic image repositories. For Ontario, for example, when you look at the diagnostic imaging repositories, there'll be 4 repositories across the province, and they will all be interconnected. So no matter where you have your image taken, your CT, your MRI, your X-ray, whatever else, and you show up somewhere else in another part of the province, they should be able to pick it up. It's not happening at this point in time in Ontario. It will be happening probably in about 18 months, but it certainly is happening in Newfoundland, it's happening in BC, it's happening in Alberta, it's happening in Nova Scotia. You could be up in the north of Nova Scotia and Cape Breton, and then find yourself at the QEW in Halifax. And if you happen to be in an emergency and they need to pull up your images, etc., they can actually access them and pull them down. So this part, the architecture part, and then the building of the standards for these different level of systems, so they can have heterogeneous computer systems communicate, was extraordinarily important. The repositories were important, and then the interoperable electronic health record, which really ties the various repositories to the point-of-care systems. So the hospital systems to the doc's offices, where there are systems in doc's offices, and I'll tell you a bit more about that. Take, for example, I know in Hamilton, they've certainly got connections between the CCSAs there, the hospitals, etc. They're just building out the interoperable electronic health record in the GTA, which will connect a very high percentage of hospitals in the greater GTA area together. And that's what we'll do. It'll feed these repositories to their point-of-care systems. The rest of the stuff above that is a bit of a sizzle on the steak. This is the tough slogging. This is the stuff that, you don't cut red ribbons on because you get a repository of drug databases, whoopee-doo. It's how do you show that off? But you can show off some of the applications you can build on that, and we funded some innovation applications that I'll speak to. We're now into funding consumer health solutions and electronic medical records in doctors' offices. We're rolling out a public health surveillance system across Canada, and I'll speak to aspects of telehealth. This is the kind of architecture I've talked about. It's got a middle layer in there, which is the longitudinal record services, and the information access layer, which connects those repositories to the point-of-care systems. It's accepted by all jurisdictions, accepted by our vendors. If you don't follow the architecture, we basically don't fund you. If you don't follow the standards, we don't fund you. We have about over 300 projects now that are active across the country. We've really done all of the registries, identifying providers of care, identifying Canadians uniquely. We have some 80 to 90% of diagnostic imaging now that's complete. There's many provinces where there's absolutely no X-ray film anymore. The drug information systems are starting to roll out across the country, including aspects of e-prescribing. Lab information systems, a lot of them are there. Telehealth, I'll speak to. Public health surveillance, again, in BC and in Ontario, they're starting to roll out some of the systems that were built across Canada. It's one thing to put these systems in, and in fact, one of the things that we've got, we had a goal to get all those paper that you see, to get 50% of that, 50% of Canadians' records that will now be available. That goal was at the end of last year. I think by the end of March, we were about 51% of availability of electronic health records for Canadians. We still got a ways to go to get to 100%, mainly because Ontario and Quebec, who really are lagging behind, mainly in their drug information systems, but we will get there. The aspect is not just making them available, the aspect is use, and the aspect is benefit. So at the end of the day, these are great inventions, but so what is the benefit? And you've always got to keep that in mind as you're building these systems, because there's significant dollars that are going into this. Not significant in the general spend of the $190 billion that we spend on healthcare every year, but significant enough that if you want more funding, you've got to make sure, so what can we quantify what those benefits are? And some of the signposts of success, here are some benefits we measured just last year. Telehealth has been a huge success. We've now touched over 1,000 communities. What does that mean? It means really that people who previously couldn't get access now can have access. What does that mean? It means that people don't have to get onto jets and planes and float planes in many cases to go see a clinician. It's a lot more convenient, a lot less miles that are traveled, and substantial savings that are made. But I think the main issue is issues of access. Imaging. The imaging story is once we're there, we're looking at about $1 billion of savings. Productivity gains of radiologists and technicians went up between 25 and 30%. What does that mean? It means we've added another 500, virtually 500 new radiologists to the system. But what it really means, it's the stories that you hear about a child being injured in Yellowknife, where they didn't have an attending radiologist, they didn't have a neurologist, and they had a visiting radiologist who was in Kentville in Nova Scotia. So they could get the images to Kentville, Nova Scotia, the radiologist could read them, and then collaborate with the neurologist in Edmonton, and then advise the attending physician whether to send the jet up from Edmonton and bring the child down to the university hospital there, or to keep the child there. And we hear a lot of those stories, certainly from the far north, and all of them are quite heartwarming, as opposed to just the bare facts here and the savings. Drug benefits, we had a pharmacare system in BC where all your prescription drugs basically are available to any pharmacist. Pharmacists that you designate. If you didn't want a pharmacist to look at them, then you could opt out of it. But very few people opted out of it. And they have systems there that will show you that the next